This is a case of right Spigelian hernia with a cyst on the right iliacs. Spigelian hernias lie in the Spigelian belt, which extends from above the internal ring to about 2 to 3 centimeters above the umbilicus. So here I have taken an eTep port. I am dissecting the eTep space, and here I am taking a cut on the medial part of the left arcuate line. Dissecting, we are reaching the hernia. I have put in another port, and what we are seeing here is actually the PRS on the right side. However, I did not realize that, and I separated and I reached the Bogrosis space laterally. What this has done is there is PRS on my right side of the screen and PRS on the left side of the screen, and this will create little difficulty later on, and we will realize how it has created this difficulty. So what I did was I worked on the PRS and then dissected the peritoneum away. So now what we have done is we have dissected the space on the left side of the screen which goes to the Cooper's ligament, on the right side which goes towards the Bogrosis space, and we have the hernia lying in between. If you are in the right plane, you can dissect the sac very easily, push it superiorly, and then lead to reduction of the sac. So once the sac has been partially dissected, I have found that there was tough tissue on the right side of the screen or on the right side of the hernia. So here I am dissecting inferiorly to make sure that if we are putting in the mesh, it should cover the inguinal spaces also and inferior to the hernia. So since I was having difficulty with the PRS, which was still adherent to the hernia on its superior aspect, after reduction of the sac, what I did was I lifted the whole of PRS onto the medial aspect, thus showing me the posterior approach to the Bogrosis space going towards the internal ring. So once that has been dissected, you can now go ahead and cut the PRS very confidently without the fear of damaging any underlying structures. Now we have reached the inguinal space, that is the internal ring here, and these are the cord structures being reflected off the peritoneum so that we can extraperitonealize the cord structures. This is the hernial defect seen from inside, and what I have done was I have used a 1O proline suture, closed the defect from inside, and then once the closure is performed well, you can put in a mesh here. However, the steep descent into the pelvis was causing the mesh to lift up on the lateral aspect. So what we did was we made a small cut in this area, and that allowed the mesh to take the contour of the pelvis. I then fixed the mesh inferiorly at 2 spots. So we have covered the inguinal defects as well as the Spigelian hernia. I then put the same ports intraperitoneally, and now I am dissecting the cyst of the peritoneum which is encompassing it. So if you're on the right plane, you can dissect the peritoneum of it very easily. Having dissected the peritoneum off on the superior aspect, what I saw was there were enlarged lymphatics in this area, and probably this was a cyst which was originating from the lymphatics, and you can see the large lymphatic channels. Having dissected the cyst superiorly, inferiorly, all that remained was the enlarged lymphatics which were feeding it and were exiting the cyst. So having done most of the dissection with the hook, I then proceeded to using a bipolar so that the feeding lymphatics could be well cauterized on either side, making sure that there is no lymphatic leak in the postoperative period, causing a lymphoria in this area. So you can see the enlarged lymphatics here. What I did was I coagulated the lymphatics on either side and then cut in between so that we don't have any leak. So once the cyst was well dissected, what I did was I put the cyst in a sterile endobag and remove the cyst. So here you are seeing the enlarged cyst feeding lymphatics. So having coagulated on either side, I cut in between, bagged the specimen, and then removed it through one of the ports after aspirating the fluid, sending it for cytology. Thank you so much.